One of my favorite Hindi movies is the 2008 film Shaurya, starring KK Menon. One of these days, I will make a video comparing Shaurya with A Few Good Men. You will surely like it. When Shaurya was about to be released, it was promoted with a single question: Shaurya kya hai?
शौर्य क्या है?
Which brings me to the topic of today's video: ATLS kya hai? ATLS stands for Advanced Trauma Life Support. What does the word trauma mean? If you're not from the medical field, let me explain. Trauma does not mean Priyatama Kato trauma from the famous Fossils song. Trauma refers to physical injury. Advanced trauma refers to severe physical injury. Trauma usually is due to an accident, but it can also be due to other more sinister reasons. So ATLS is teaching doctors how to treat patients with severe physical injuries. All doctors? Yes. Everyone with an MBBS degree? Everyone with a BDS degree? Yes, dental surgeons are also included in learning about ATLS. So ATLS effectively ends the much long drawn out debate about whether dentists are doctors or not. If you are familiar with debates from school, you must have heard about this topic: are dentists doctors? And one of the most frequently used lines to accuse dentists of not being doctors is that, can dentists save lives? No. Then how can they be doctors? Yes, they can save lives. That's point one. Point two, if they participate in the ATLS students course and learn about ATLS, then they can definitely save lives, and save lives better than many doctors who do not have ATLS certification. So that debate was long dead, but it has been buried effectively by the ATLS program. The basic philosophy of ATLS is to enable every doctor to provide a uniform framework of care to stabilize every injury victim, no matter how severe the injury is and no matter how small the hospital is. This care can be provided with limited resources at almost every hospital, with the view to stabilize the patient and then transfer the patient to receive definitive care, either in the same hospital if facilities are available, or in the nearest hospital where such facilities are available, the facilities that are needed to provide definitive care to the particular injury victim. In this video, I will try to answer a dozen questions, 12 important questions. Question 1. Why is ATLS needed? Question 2. How to provide emergency care to injury victims? Question 3. When do we decide to transfer the patient to a different hospital? Question 4. When do we transfer the patient to a different hospital? There is a difference. When do we decide to transfer? And question 4 is, when do we actually transfer the patient to a different hospital? Question 5 is very important. What should we not do while stabilizing the patient? Keeping in mind the differences in treatment depending upon whether the patient is very young, very old, or pregnant. Important point here is every female in the reproductive age group is assumed to be pregnant unless otherwise proven by a pregnancy test, a negative pregnancy test. Who is providing this treatment? How is this treatment provided? The mechanisms of injury are really limited only by our imagination. So if injuries can happen in infinite mechanisms, how can there be one universal framework to treat every injury victim? The second last question, how did advanced trauma life support start? And finally, who provides advanced trauma life support training to doctors? The answer to the last question will surprise you. Why is ATLS needed? ATLS provides standardized care to every victim of severe injury. It provides a framework, an algorithm, a protocol, or to oversimplify it, a checklist with the help of which every doctor can treat every injury victim in a systematic manner in every hospital, even if the hospital is resource limited. It takes away a very common excuse from doctors working in rural hospitals. An ATLS trained doctor will no longer say, I don't have any facilities here. Why did you bring your patient here? Please take your patient to the nearest big hospital. I hope you can understand how ATLS is beneficial to both doctors as well as to patients. Now you must be thinking, what is this simple framework that can help every doctor stabilize every injury victim in every hospital in every part of India? I know the ground reality. I'm not blind to it. I know there are hospitals where there are oxygen cylinders but no oxygen, or there are oxygen-filled oxygen cylinders but no person available to connect the oxygen cylinder to an oxygen mask. ATLS cannot solve problems related to dearth of skilled personnel or problems related to human incompetency. However, ATLS is still a step in the right direction because it aims to provide a standardized framework of care to doctors so that they can utilize them to care for injury victims in every possible situation, in every possible hospital, even if it is severely constrained in terms of resources. ATLS is a step in the right direction because it aims to change the mindset of and ground reality for doctors working even in rural hospitals who are trying to provide emergency care to victims of injury. Back to the simple framework. It is as easy to execute as it is to remember. It is as easy as A, B, C, D, E. This, of course, is the initial assessment, which can be done in as little as 10 seconds if you know what you're doing. Initial assessment is followed by secondary assessment, provided the patient is stabilized after initial assessment and management. Secondary assessment is a detailed head-to-toe examination of the patient. But let's come back to ABCDE. What does ABCDE stand for? A for airway and cervical spine control, B for breathing, C for circulation, D for disability, and E for exposure and environment control. Let's explain them one by one in a language so simple that even my parents could understand it. The main philosophy behind ABCDE is to treat that part of the human body first which can kill the human being fastest. In that spirit, the first part that is addressed is the airway. Airway is the path followed by air that we breathe. It starts in the nose and ends in the lungs. You can imagine it to be a highway for air, airway. Here there might be some confusion regarding what is airway and what is breathing. How do we differentiate between the two? So let's use the highway analogy a little bit further. The road, the highway, is the airway, and the vehicles on that road can be imagined to be breathing. Now, the vehicles may not be moving because of vehicular issues, maybe engine failure, maybe lack of fuel, maybe incompetent driver. But if the airway is not functioning properly, the highway is blocked due to rare instances of bridge collapse. You know, it never happens in India, it's very rare. Then all vehicles, no matter how top-notch they may be, will come to a standstill. So the first priority is to look at the highway, in this case airway. Is the highway blocked or not? Is the airway patent and secure or not? So that's the airway part. Before I forget, airway also includes cervical spine control. Let's talk about cervical spine control now. Cervical spine control is incredibly important because it can worsen the situation rapidly. It is very important to immobilize the cervical spine because if the cervical spine is not immobilized, it may cause or worsen cervical spine injury. And cervical spine, that is back of the neck injury, is incredibly serious. It can lead to paralysis of the limbs, that is hands and legs in simple language. But even more so, cervical spine injury can even lead to death because some nerves that come out from between the two cervical vertebrae control the movement of the diaphragm, which is the most important muscle responsible for respiration. That is breathing in simple language. There is even a mnemonic, C3, C4, C5 keeps the patient alive. So that's how important cervical spine control is. How do we do this? Only two very simple pieces of equipment are required for cervical spine immobilization. A semi-rigid cervical spine collar, not the soft ones, they don't help at all, and a spine board. Preferably, patients should be transported from the site of injury to the nearest hospital and from the nearest hospital to a hospital a little farther away for definitive care at all times on a spine board with a cervical spine collar, a semi-rigid one in situ. It is a good practice to assume that cervical spine injury or spine injury is always present unless otherwise proven. That way, chances are a doctor or the ambulance staff is not going to make a bad situation worse or inadvertently cause spinal injury while transporting the patient from point A to point B. And with that, we have described A in ABCDE. Let's move to B. B for breathing. Let's understand breathing by carrying on with the highway analogy. The highway or the airway is spectacular. Think of the Yamuna Expressway. It is in pristine condition, but the vehicle breathing is not happening. It's not moving forward. Why not? Maybe it has run out of fuel. Maybe there are other factors obstructing the path of the vehicle, not the road per se, but maybe other vehicles obstructing the path of this vehicle's onward movement. So even in a situation where the airway is completely patent and completely secure, breathing can still be compromised. The conditions that can compromise breathing in the absence of visible injury are tension pneumothorax, massive hemothorax, cardiac tamponade, just to name a few. Of course, injuries to the lungs, ribs, and heart can also compromise breathing. How do we assess if such an injury has occurred or not? Simple. Expose the neck, expose the chest. Examine the neck and chest not just for visible marks of injury like a cut injury or a bruising, but also look for engorged neck veins. Also look for the chest wall movement is abnormal or not. Don't forget to use your stethoscope to listen for breath sounds as well as heart sounds. Remember, tension pneumothorax, cardiac tamponade, massive hemothorax, these may sound like extremely difficult conditions, but the initial treatment remains the same. Either introduce a needle or a tube to drain out air or blood. Yes, sometimes even air can accumulate and prevent breathing. That's paradoxical, but it can happen. Too much air in the wrong place in the chest cavity can prevent breathing. This is the tension in tension pneumothorax. C stands for circulation and control of hemorrhage. This is perhaps the easiest term to understand. All efforts must be made to ensure that blood continues to reach the vital organs, heart continues to pump properly, and any bleeding is identified promptly and controlled effectively. D talks about disability, but in the context of ATLS, it talks specifically about neurological disability. To understand if an injury victim has some form of neurological disability, one needs to take into account the Glasgow Coma Score, the condition of the pupils, and if any lateralizing signs are present or not. Big words, I know. Let's simplify them. Glasgow Coma Score can be assessed by checking if the patient can open their eyes on their own or not, if the patient is able to respond to simple instructions properly or not, and if the patient is able to speak normally or not. That's Glasgow Coma Score, or the common abbreviation GCS when doctors want to save precious milliseconds. The pupils are small openings in our eyes. We have two eyes, so we have two pupils, and the way to assess them is to compare the two. Are they both equal in size? Are they both equally round? Are they both equally reactive to light and accommodation or not? Any abnormality in the pupils can indicate the presence of serious injuries like injury to the brain. E is the easiest. E refers to exposure and environment control. It is very important to remove all clothing from the injury victim to examine the entire body to not miss out injury to any part of the body, including injury to private parts. But while examining the patient, it is very important that once we have removed the clothes, there is a possibility that the patient may develop hypothermia, that is reduction in the body temperature. So that needs to be prevented. The way to prevent this is environment control. We will talk about environment control in more detail in a short while, but I need to digress mildly here. Human beings started wearing clothes to keep themselves warm. I know. That's why in most parts of the world, being naked on a warm sunny beach is considered to be normal. However, in the modern context, most of us wear clothes because we want to conform to the norms of society. We are wearing clothes because everyone else is wearing clothes. So once you remove the clothes of a patient, there is a possibility the temperature of the body of the patient can fall, especially in an air-conditioned room in a hospital in India. In cold parts of India, one should examine the patient very quickly and quickly cover them up with a warm blanket. In other parts of India, if there is a powerful air conditioning in the emergency room, that should be switched off before the patient enters the area, because the life of the patient is much more important than the comfort of the doctors and the other medical staff present. Another key aspect of environment control is when fluids are administered, whether they are crystalloids like normal saline or blood products, they should be warmed first. Because if you have kept the external environment well in control and you are administering unwarmed fluids, then the temperature of the body can still fall. And with this, we have concluded the entire ABCDE. I did tell you that this entire thing can be done in only 10 seconds. How can that possibly be? It took me such a long time to explain it. How can I do it in 10 seconds? Start the clock. A patient comes into the emergency. He has suffered injury. Hello, I am Dr. Pushpin Das Gupta. What's your name? How did this happen? If the patient answers that question properly, in a good quality voice, in a correct manner, then I have already found out all I needed to know. If their voice is normal, then the airway and breathing are also normal. You can think of voice as a Ferrari on the highway. You might not see it, but if a Ferrari is running smoothly, then both the highway as well as the traffic is in optimum condition. The same path that is followed by air for breathing is also the path followed by voice production. So voice production indicates that airway and breathing is normal. And if the answer is proper and coherent, it makes logical sense, then the brain is working properly, neurological defect is not there, and chances are that blood is reaching the brain properly also. That means a lot of bleeding has not occurred so far. So in 10 seconds, I found out so much. When to decide that a patient requires transfer to a different hospital? This decision can be made even before the patient is received at a given hospital. Because in an ideal world, before a patient is brought to a hospital, the ambulance staff who is transferring the patient from the accident site to the hospital should inform the receiving doctor that a patient who has suffered this kind of an injury is being brought to the hospital. And if the doctor finds out that the patient has suffered severe head injury and no neurosurgeons are available in that particular hospital, the doctor can decide immediately that definitive care cannot be provided in his hospital. In that situation, he will know that for definitive care, he will need to transfer the patient to a different hospital. In that situation, should he tell the ambulance personnel that don't bring the patient to my hospital, take the patient directly to a hospital with neurosurgical facilities? The answer is no. The decision to transfer the patient can be made while the doctor receives the news, but the actual transfer of the patient should only happen after stabilizing the patient in the hospital, because as I said, ATLS teaches every doctor to stabilize almost every patient in almost every hospital, regardless of the resources available to the doctor. Let's see when the doctor decides to actually transfer the patient. Like I said, there is a difference between deciding to transfer the patient and actually transferring the patient. Before transferring the patient should be stabilized. Note, I am not saying cure the patient. Curing the patient would require definitive care. Definitive care would require the input of a specialist who may not be available everywhere. Neurosurgeons are not available everywhere. So you might have to ask the patient to be sent to a different hospital. But the patient should only be sent to a different hospital after he or she has been stabilized. ATLS teaches doctors to stabilize almost every patient. So after ABCD, what should you do? There are some adjuncts as well. What do these include? These includes introduction of certain tubes, IV cannula, nasogastric tube, Foley's catheter, certain investigations, chest X-ray, pelvic X-ray, FAST, that is fast assessment with sonography in trauma patients. E-FAST is extended FAST, that is assessment of both the abdominal cavity as well as the thoracic cavity to look for intra-abdominal or intrathoracic hemorrhage. The pelvic X-ray, if it's found to be abnormal, then a pelvic binder can be used. No other investigation or intervention is really necessary in the emergency setting. CT scan should be sparingly used, and it has very specific scenarios where CT scan is required in an emergency patient. So an important learning point here is every head injury patient does not require a CT scan. How to transfer? Patient should be transferred to the nearest facility which has definitive care options available that the patient requires for definitive treatment. So if a hospital is 50 kilometers away and that's the nearest hospital with a neurosurgeon, that's where you should send the patient. But before sending the patient, ideally the transferring doctor should call the receiving doctor. Inform the receiving doctor about the details of the patient, the mechanism of injury, the description of the injury, the description of the treatment provided, the condition of the patient at present, and also ask the receiving doctor if any further treatment should be administered or any precaution should be followed while the patient is being transferred from the transferring hospital to the receiving hospital, because 50 kilometers takes time. During that time, some treatment might be required which can be possible to administer inside the ambulance that the neurosurgeon might be able to tell. So this conversation is very important between the transferring doctor and the receiving doctor. It's of paramount importance. Now this is interesting. What should a doctor not do while stabilizing a patient? The doctor should not concern themselves a lot with a detailed history, because the primary priority is to stabilize those parts of the body that can kill a patient fastest. Stabilizing a patient does not require detailed history. It also does not require a lot of investigations. The investigation that we have mentioned, like chest X-ray, pelvic X-ray, ultrasonography, that is FAST or E-FAST, that's enough. You can go for some routine blood test, nothing beyond that. You should not waste precious time trying to get lots of tests done, because even if you find many pathologies, they may not be treatable at the hospital where you are providing emergency care. So why do the tests in that hospital? Those tests may also be repeated at the hospital where you are transferring the patient. That is wasting precious time. Also, detailed history again is not necessary for ABCDE, for stabilizing the patient. So why take that detailed history? Why waste time? However, if the patient is stable and you have a chance to do secondary assessment, then you can do detailed head-to-toe examination, you can take detailed history, and you can go for further investigations. But only when the patient has become stable, not before stabilizing the patient. So these are the things that one should not do while stabilizing the patient, and it is a very important change in the mindset of doctors. Because as doctors, most of us have been trained that the first thing we need from a patient is a detailed history, then clinical examination, and then we come to a diagnosis, and then we go for more investigations to confirm our diagnosis, and then we go for definitive treatment. That approach does not work in an emergency setting. Emergency setting, it's all about A, B, C, D, E. First, stabilize the patient. Don't worry about the diagnosis. Don't worry about the history. Don't worry about prescribing the appropriate investigations. It's a very important change in the mindset, which I believe is the single most important contribution that ATLS has made to me personally. Injuries are different, and treatment is also different depending upon whether the patient is very young, very old, or pregnant. A small trauma, a trivial trauma, can lead to serious injuries in the very young and the very old. In treating pregnant women, we have to remember that we are not just treating one life, but two lives. Certain signs of injury become apparent at a much later stage in pregnant women. So the key aspects of treating The very young, the very old, and the pregnant are very important to remember in order to avoid disastrous consequences. One of the key things that we find very difficult to remember as doctors, unless we are pediatricians, is the doses of medicines for children. In an emergency setting, a tape can be used which has doses of medicine corresponding to height or length of the child. This is a very useful tool in the emergency scenario. Who is providing this treatment? Any doctor can provide this treatment. I know emergency medicine is now a recognized specialty. So of course emergency physicians do have an edge, but every ATLS trained doctor is also capable of providing emergency treatment. ATLS is not restricted to any given specialty or a group of specialties. It's not just for surgeons, it's not just for physicians, not just for specialists, it's for all doctors. It also includes, as I previously stated, dental surgeons. So anyone who has completed ATLS can provide emergency care to every injury patient. In fact, dental surgeons can not only participate in ATLS as students, but they can also participate in ATLS as teachers. One of the teachers of the ATLS session I attended in the venue behind me was a dental surgeon, and he probably delivered the best lecture of them all during the 3-day course that I had attended in King George Medical University in Lucknow. We have been through this before. I don't want to repeat myself, but the key thing to reinforce is that the treatment advocated by ATLS, primary survey, secondary survey, the entire thing can be provided in almost every hospital, regardless of how acute the resource constraints might be. Every doctor can provide this treatment. All the doctors need are basic equipment like oxygen facilities, intubation facilities, X-ray facilities, ultrasound facilities, IV cannulation, chest tubes, blood bank, compression dressing, pelvic binder, cervical spine collar, nothing beyond that. Usually this is enough to stabilize a patient. No fancy facilities are required. Nasogastric tube, Foley's catheter. If a pelvic binder is not available, a bed sheet can also be used as a pelvic binder. So usually these facilities are enough to stabilize a patient. That is the crux of ATLS, to teach every doctor to treat every patient in every hospital with an aim to stabilize them. That is indeed a very pertinent question. The mechanism of injury is very important because the mechanism of injury along with the age of the patient helps us guess which parts of the body are likely to be injured. And yes, any part of the body can be injured in so many different ways. But the key thing for an ATLS trained doctor to remember is to focus on that part of the body first, which can kill the patient fastest. Regardless of the mechanism of injury, regardless of any other details, the priority of treatment in the ATLS context is always A, B, C, D, E. It was a joke during the session that I attended that an ATLS trained doctor can be woken up in the middle of the night and the first thing he'll say is A, B, C, D, E. The priorities of treatment in every situation remains A, B, C, D, E when treating an injury victim. ATLS, like all other good things, started in the great country of the United States of America. The story of its genesis, however, is rather tragic. There was an American orthopedic surgeon who was flying his aeroplane. This aeroplane crashed. He suffered severe injuries, his 3 children suffered severe injuries, and his wife sadly passed away during this accident. This led to the orthopedic surgeon understanding that the system needed to be changed. On your screen, you'll see his exact quote after this incident. The American College of Surgeons took note of this incident and they started advanced trauma life support in a few years' time with an aim to train American doctors first, and later on it spread to other parts of the world. Because of the tragedy that befell one American orthopedic surgeon, doctors all over the world got an opportunity to learn ATLS. Consequently, patients all over the world are also benefiting. So So, people who receive ATLS training can provide emergency care to every injury victim. But who provides ATLS training? ATLS training can be provided by American College of Surgeons certified instructors only. How to become an instructor? To become an instructor, one has to attend an ATLS students course. During that course, if a student is identified by the ATLS certified instructors as having instructor potential, then this individual can participate in an ATLS instructors course. During this instructors course, the student would be taught how to teach ATLS. Then the student needs to teach ATLS, and if the student is teaching ATLS properly, then they become certified ATLS instructors. I am one such student. I was identified as having demonstrated instructor potential during the ATLS provider course from 19th June to 21st June 2025 in King George Medical University, Lucknow, and if I choose to go ahead with becoming an instructor, I can choose to participate in the ATLS instructors course. So who knows, when you, dear viewer, decide to participate in the ATLS provider course, I might be providing you ATLS training. Told you, this answer would surprise you. Thank you for watching this video. Take care, bye bye, and please don't forget to be awesome.